Well, ladies and gentlemen, I'd like to kind of introduce Dr. Yodit Tefera. Dr. Yodit Tefera has been with us for a couple of years now. She's done an amazing job. She is a PM&R doctor, a physician, medicine, and rehab doctor who has done a sports medicine fellowship after her training in PM&R. She's an avid runner and has run many marathons. And in her free time, she also serves as a model for Pacers. If you happen to check out Pacers runners, she's right on their front page. So she's going to give us a talk today about kind of patients that are in the treatment gap. And I'm just going to pass it on over to Dr. Tefera.
Thank you for the introduction, Dr. Farrell. So I guess I'll start again. Thank you, Dr. Farrell, for the introduction and the opportunity to give this webinar this afternoon. Can't see everyone on the call, but I imagine there's some amazing patients that are here, and I will be talking to you all about the treatment gap. We'll go into what that is in a little bit more detail. If you do have questions that come up during the presentation, you can always put them in the chat feature below at the bottom of your screen, and we'll do our best to try to answer those questions at the end of the presentation. So like Dr. Farrell mentioned, I am board certified in physical medicine and rehabilitation, as well as sports medicine. I joined ROSM over 2 years ago, and it's been a great time here. I am a runner, so I have a particular interest in running medicine and running athletes, but I really like helping just the general population of people who like to stay active and maintain their quality of life. So just briefly to review the outline of this presentation, what we'll be doing is defining and talking about what the treatment gap is. After that, we'll discuss what treatments are available to patients who happen to fall within the treatment gap. And then lastly, talk about how we as ROSM providers can help you if you do happen to fall in this category of patients. So what is the treatment gap? First, I want to thank Dr. Michael Oriama, one of my colleagues, for sharing his slides with me. I thought this picture was a great kind of analogy or a way to think of what the treatment gap is. On one side of the road, the side closest to us, we see there are patients who've received conservative treatments. On the other side of the road, there's surgery. Most patients that come into our office are trying to avoid surgical interventions. So the treatment gap is kind of that period of time where the patient's tried all the conservative treatment options, but yet hasn't met that improvement that they're hoping for, but isn't quite ready for surgery. So as you can imagine, a lot of patients may fall into that gap of time or that treatment gap. And there are additional treatments available to patients outside of the more conservative treatment options that can get them feeling better. And that's what we'll discuss in detail today. So this is a study that outlined a little bit more detail about the treatment gap. It was published in 2011. They go over clinical and economic consequences of the treatment gap in patients that are specifically suffering from knee arthritis. And so what happens is, as you can imagine, once you've exhausted all or most all conservative treatments, but don't want to get surgery, you're stuck in this place where you have pain, where you're having it impact your quality of life. You can't go out for a walk, you can't run like you like to run. And so these patients, for several years, spanning anywhere from 9 to 20 years, are dealing with progressive pain, impacting their quality of life, and in some cases having more of a financial burden on them, where they're not able to do the work that they were used to doing prior to their pain coming on. So I'll talk a little bit about what these conservative treatments are in orthopedics. So as ROSM patients or people who are interested in getting better, I anticipate you guys are somewhat familiar with some of these treatments. Weight management, managing your weight appropriately, is fundamental to a lot of orthopedic conditions, patients that have knee arthritis, hip arthritis. You want to make sure that you are working towards obtaining a weight that is appropriate for your body habitude. Physical therapy is really at the core of a lot of what we do. I personally believe most all of these treatments won't be successful unless you have a strong foundation in exercising and strengthening these areas. And really what you learn in PT and continue on your own is what's going to help you maintain and prevent further injuries going forward. So physical therapy, absolutely important, whether it's with the therapist or on your own. The last two are more pain management strategies, oral medications like anti-inflammatories, Advil, naproxen. Those are medications that can help with inflammation. So if someone has knee arthritis, shoulder arthritis, they may, for a short period of time, take anti-inflammatories. And we'll go into a little bit more detail about these last two. And then cortisone injections, a pretty common thing that we hear about and that I hear from a lot of my patients that they've received. There are certain limitations with these last two treatments. So NSAIDs or anti-inflammatories, these medications are processed through your body. They're processed through your kidneys. So patients who have history of kidney injury may be limited in how much they can take. Patients who have stomach ulcers or stomach inflammation may also not be able to take anti-inflammatories for long periods of time. And so really we limit how much and how long you're using these treatments because they can in the long term cause more damage than good. Cortisone injections. So short-term cortisone is an anti-inflammatory. It does and can provide acute short-term relief in acute cases. So if someone comes in and they've sprained their ankle or fallen and bumped their knee, that may warrant a consideration for a cortisone injection because that's an acute injury that has acute inflammation. A lot of what we see in our office is more of a chronic issue. Someone who's had arthritis for a long time, someone who's injured their rotator cuff a long time and is still dealing with the issue. So for more chronic issues, we understand that cortisone only lasts for so long. So it's not necessarily a great way of managing those symptoms. And there are plenty of studies that show us that repeat use of cortisone can cause progression of arthritis, wearing down of cartilage. Oral steroid can cause weakening of your bones. So in the long term, it can have more toxic effects than good. And so we try to use those in appropriate situations when we do discuss them in our clinic. And then this is not conservative. This is probably as aggressive as it gets, but surgery. So I thought this article was interesting. It was published in 2017 in the Journal of Arthroplasty, and they looked at patient dissatisfaction following total knee replacements. And they found that there was a 20% dissatisfaction rate post-surgery. Well, you know, that's not reassuring, right? If you're going in for this treatment, you want to at least have hope that it's going to get you relief. But it is an invasive treatment. They are cutting through tissues. There are possible complications that can come from getting surgery. So why not make sure you've exhausted all other options before going down that route? So I'm going to talk about the treatment gap specific to knee arthritis next. So if we go back to the image, these are the more conservative treatment options that we discussed: weight loss, diet and exercise, physical therapy, medications, injections, cortisone injections. And then this is where I'll often see patients who've tried some of these, or with working together, we've tried to get them feeling better with physical therapy, but they really want to avoid knee replacement. And so what can we offer them? Well, that's where we introduce regenerative medicine or regenerative treatments. So you may ask, what is regenerative medicine? This definition I got from the NIH website. Regenerative medicine is an emerging area of science that holds great promise for treating and even curing a variety of injuries and diseases. So what we try to do is use your body's own cells and growth factors to promote a healing process to occur. And ultimately, our goal is to reduce your pain and improve your function. What are these treatments? I'll break each of these down individually, but prolotherapy, PRP, or platelet-rich plasma, and then there are a group of cellular therapies where we use your mesenchymal stem cells in order to elicit that healing process. And those cells can come either from your bone marrow or from your fat. So first, prolotherapy. Prolotherapy is a solution of dextrose. Dextrose is sugar water. So it sounds kind of funny that sugar water could help, but we found that injecting this solution of dextrose into areas of injury can first act as an irritant that tries to stimulate a healing response. The body sees this irritation and tries to send cells to help promote the healing process to occur. So there is evidence in the arthritis that shows it can help with pain, function, and stiffness. One great benefit from prolotherapy, if you are an appropriate candidate, is that it has minimal downtime. Often patients are coming in and have pain for about 24 to 48 hours maybe after the injection, and are going back to their daily workouts, their daily exercises with minimal discomfort. So prolotherapy is one of the 3 or 4 regenerative treatments that could be considered. The next one is platelet-rich plasma. You may recognize these 2 athletes on the left. Kobe Bryant and Tiger Woods both received PRP injections to their knees. PRP can be used in osteoarthritis, tendon and ligament injuries. There are multiple level 1 studies that show that patients do receive benefit from treatments to these areas. On the right, you'll see a woman getting a PRP injection to her scalp for hair loss. Even Kim Kardashian made the vampire facial pretty popular, so PRP can be used for more cosmetic purposes as well. In our sports medicine branch of ROSM, focus more on the arthritis, the tendon, and the ligament injuries. And so what are platelets? This is a picture of your blood. And your blood contains different cells. Red blood cells, the purple cells are platelet cells. And so these platelets are found in your blood. When a patient comes in for a PRP injection, what we do is draw your blood and then use our centrifuge machine to isolate out your platelet cells. These cells are the cells that are responsible for releasing growth factors that promote healing. And so once we've gotten your platelet cells in a syringe, we inject them into the area that you have an injury to, whether it's your knee joint that's causing your pain, your rotator cuff that's causing your pain, your ankle causing your pain. We inject these cells, these powerful cells, into those areas to promote a healing process with the ultimate goal of eliciting or improving your pain levels and improving your function. And then lastly, we have our cellular treatments. So these treatments involve using your mesenchymal stem cells. On the left, and they look pretty invasive, but they're not as scary as it looks in this picture. I'm sorry if it does look scary, but the first one is bone marrow aspirate concentrate procedure. It's a procedure where we isolate or take out your bone marrow cells from your hip or your pelvis. It involves kind of poking a hole in your pelvis. Sounds really bad, I apologize again, but drilling a hole in your pelvis to isolate these very potent blood cells that we then process and inject into the area of injury. The alternative to that is where we use your fat cells. Here you can see in the syringe that fat is being harvested from what looks to be the flank area, kind of like a mini liposuction. All we're doing is harvesting some of your fat. These adipocytes or fat cells also contain these strong mesenchymal stem cells that are able to further differentiate when we put them into the tissues to help promote healing processes to occur. So in summary, regenerative treatments in summary, they're treatments that are working with your body to promote a healing process to occur, really without surgical intervention.
You know how to turn off my computer?
Without putting in any prosthesis, without putting in any foreign devices in your body. All we're trying to do is reset and restore the natural healing process that we want to occur in our bodies. It's first very important to have an accurate diagnosis, to be clear about what it is that's causing your pain. Is it just arthritis? Is it arthritis and tendonitis? Well, just treating one of them may get you some relief, but being more comprehensive and making sure we're treating everything that we can treat will help make sure we get you to your optimal level of improvement. These treatments should be done with image guidance. So at ROSM, we make sure to use ultrasound guidance for almost all of our procedures. Ultrasound is a modality that allows us to look at different structures in the body. We can visualize muscles, tendons, ligaments, and joints. And that's really important when we're putting these substances into your body. We want to make sure we're getting it into the right spot. And so using image guidance will only optimize the outcomes for our patients. And lastly, wherever you decide, hopefully it's the ROSM, if you do decide to pursue these treatments, you want to make sure you're going to a facility that is following FDA guidelines. There are a lot of places that offer these regenerative treatments, and so making sure you're seeing a provider that is following evidence-based medicine, up to date with the literature, and following FDA guidelines is ultimately very important. So what are reasons to consider these treatments? Well, the first one is if you fall into the treatment gap. If you feel like you've done PT 2 or 3 times and really have met a plateau, if you've been working on losing weight and doing the exercises on your own, but you still are having some limitations to your quality of life. It hurts to walk, it hurts to bend your knee. Well, that's a reason to at least consider or have a conversation about this treatment. Some people are unable to get surgery because they have really stringent work restrictions and they can't be out of work for 6 weeks or 8 weeks or however long it may take them to recover. Well, the recovery time for these treatments are often, they can range from a week or 2, but not typically 6 to 8 weeks of restricted mobility. And so that's another reason why patients pursue these treatments. Other people just aren't able to get surgery. They may not be able to tolerate anesthesia. They may have other conditions that limit them from being able to undergo surgery. Well, then at that point, this might be the only route that they have. And lastly, and more commonly now that there's more research and more out there about these regenerative treatments, patients are coming in asking. They see something in the newspaper, they see something about an athlete that received these treatments and want to know if it's appropriate for them. Most of the time, we are not doing these treatments on professional athletes. We're doing them on people that are coming in, having dealt with pain for many years in whatever joint or body part and wanting to get better. And asking, I think, is the first step, and having that conversation afterwards will help determine if these treatments are appropriate for you. And then ROSM's approach to the treatment gap. So when I'm seeing a new patient come in, first what we do is have a conversation. We talk about what it is that's bothering you, what your goals are. Some people have a goal of running an ultra marathon. Other people are happy to be able to walk down the block and not have pain, So identifying what those goals are helps the treatment plan, or helps us make a treatment plan. We do a comprehensive assessment. So a thorough physical examination is done. Like I said, we do ultrasound evaluations on all of our patients that come in and try to visualize the areas that have injury. And then lastly, once we've gotten a clear idea of what your goals are, once we've gotten a clear idea of what the diagnosis is, we make up a detailed plan and then talk through what the appropriate procedure may be. It may be that we continue to exhaust some of the conservative treatments, and then we keep some of these regenerative options as a plan B. It may be that, hey, you've done all of the conservative stuff, you've done your part, and now we have to introduce the next step. But we have that conversation and make up a treatment plan based off of that. So that is my talk today. That is what the treatment gap is and means to me. Don't know if there are any questions in the chat yet, but if you have any questions, I'm happy to answer them.
Thank you, Dr. Tefera. That was excellent. So if you guys have any questions, there's a chat button at the bottom. You can click on the chat button and type your question in, and we'll have Dr. Tefera kind of answer those. But I have a couple just to kind of get you started off with. You had mentioned level 1 evidence or level 1 studies. Could you explain that a little bit more for us?
Yeah, so when we look at studies, or when we talk about studies, what we want to make sure are that people are looking at randomized controlled trials where they're having patients separated into the appropriate groups, where there's potentially a placebo group where one group is receiving treatment, another group is receiving non-treatment, and then kind of looking at the outcomes from that. And so those level 1 studies have been done on knee osteoarthritis, have been done on elbow tendinosis or tendon injuries, and have shown that specifically looking at the outcomes of pain and function, that there have been benefits seen for treatments with some of these regenerative.
Excellent, excellent. Well, one of the questions that popped up in the chat was, has FDA approved PRP treatments?
To my knowledge, and I did look on their website prior to this presentation, it's still considered experimental by the FDA, and we make sure our protocols are in line with what the FDA is requiring of us, but it is not yet approved or cleared by the FDA or insurances.
Yeah, so to add a little bit to that, FDA is not going to approve. So PRP is considered a blood product. FDA really kind of focuses on approving drugs, and because they don't consider PRP a drug, they're not going to approve it. A PRP can be made using an FDA cleared kit, which we use. One of the kits we use is something called MSite, and so they have approved the kit that they use to process the plasma, but they're not ever going to say, yep, PRP is an FDA approved treatment, because it's outside of what they typically regulate.
Okay, that makes sense.
Somebody asked, can you discuss your experience with kind of 10X and 10X bone or 10XB?
I'm glad you're on the call, Dr. Farrell. I did a lot of that during my training. It was primarily for patients that have tendinosis or tendon injuries. Instead of injecting these regenerative treatments that we mentioned, you put this 10X device that is able to send, I believe they're sound waves, Dr. Farrell, and take out the pathologic or injured tissue while leaving in the healthy tissue. And that has been shown to be beneficial for tendon injuries. Dr. Farrell, if you have additional information to share.
Yeah, like Dr. Tefera said, so it's a machine that oscillates back and forth approximately 100 times per second to create these ultrasonic or sound waves to break up scar tissue without damaging the healthy tissue. It can also be used on kind of small kind of bone spurs also to break down the bone spurs. So while it's oscillating, it's going to heat up very fast. So it also is injecting water or spraying water in at the same time to keep it cool, and then having hooked up the scar tissue or the calcification that's there. So essentially it's a minimally invasive surgical procedure, and therefore it's going to have, a more significant kind of, recovery time. So we're actually debriding or breaking away that scar tissue. So as that's removed, it's going to take, a couple of weeks for things to kind of calm down. And we usually get you back into physical therapy. And usually when I see people at about 6 weeks, I expect to see somewhere around a 50% improvement of their pain. And then usually are clearing people closer to 3 months out. One of the next questions that we have was, have you been doing this long enough to observe a percentage of patients that still do knee scope surgery after multiple regenerative procedures?
I have had a few patients that have gotten 2 or 3 PRP injections and ultimately ended up getting a knee scope. In those cases, there have been more involved injuries outside of potentially what we can treat with just PRP alone. So someone may have a meniscus tear in their knee, and we treat the meniscus, and the meniscus gets better. But if there's also damage to the cartilage surface of their knee, that PRP alone may not address that area, and they may need more of an invasive surgery to help repair that. That's been one situation I've experienced.
Yeah, I think you're completely right. So it really depends on the exact situation that we're treating. If we're treating a very simple, minimally displaced meniscus tear, we have a very high success rate, probably close to 80%. If there are other complicating factors, such as a loose body that's rolling around in there, that can cause problems, and you may need to kind of go and have a knee scope afterwards. As Dr. Tefera is saying, if there's something called an osteochondral defect, so areas with high loss of cartilage, so just treating the meniscus itself may treat the soft tissue, but may not fix that osteochondral defect. They may need a scope for that. And so, these are the things that we kind of try to evaluate the MRI first before we start to do that, just to make sure we're not missing anything. And, picking the right patient population for PRP is going to be very important. And then the other thing that we have to look at is, the association of osteoarthritis. So if you have a meniscus tear with associated osteoarthritis, we have enough studies now that looked at both surgery with a knee scope versus a sham surgery, where They put poke holes in, put water in, and then just took it out, but didn't even do any surgery. And at about a year out, we found that the group that had the sham surgery did better than the group that actually had the debridement surgery. And so that kind of leads us to believe that operating on meniscal tears with associated osteoarthritis is not going to be a long-term benefit. And so we typically try to offer some of the regenerative treatments for those patients rather than putting you through a knee scope, which may give you 6 months to a year relief, and then now you're progressing down that pathway to a knee replacement.
Mm.
So I have another question for you, Dr. Tefera. This is one that kind of gets asked to me pretty often. Is when we start talking about some of our cellular treatments, the bone marrow, the microfragmented fat, some patients, say, "Hey, I hear that baby stem cells are better than my own stem cells. Should we be using baby stem cells for me?"
Yeah.
What would be your answer to that?
Well, as last I am aware of, the FDA has banned any use of kind of placental or baby stem cells to be used in practice. And so I would say we do not perform those procedures. And your stem cells are actually, your own stem cells are pretty powerful in their ability to heal, despite you not being a baby. So I would say, I think your own stem cells are more potent and appropriate use.
Yeah, and I think the other thing that I would like to add to that is that when we look at the amniotic fluid or the amniotic cells that are out there, what FDA has said is that in order to create that, it's more than minimal manipulation, so they consider it a drug. And as such, they wanted to go through all the proper drug testing. So there's a lot of companies out there that are going through proper drug testing. It's probably going to take a couple of years before it comes out. Second thing on that is that if we take fat out of your body and try to grow stem cells from the fat, or if we take bone marrow out of your body and we try to grow stem cells from the bone marrow, we can grow both of those things. When we would take the amniotic fluid and try to plate it and grow it in a lab, nothing would grow. So what that tells us is that there is no live stem cells in those treatments. There were growth factors, just like there are in the plasma, and we think that that's probably why people were getting benefit. So we don't necessarily, we think that some of it is really a misnomer to call it baby stem cells because there were really no live cells there that would turn into new tissue. And it looks like we have another follow-up question. Does surgery undo the partial healing from the regenerative procedures, or does it add benefit on top of it?
Well, I imagine it depends on what the surgery is. If they're going in for the meniscus and they usually don't repair it. They kind of just cut out the portion of the meniscus that is still injured. I would imagine that it's not necessarily doing much to help or treatment that you've received.
Yeah, but I think just to kind of add on to that, everything really depends on your specific case. So there are certain cases where I have patients with a bucket handle meniscus tear. So this is a meniscus that's kind of folded in half. Once it's folded in half, there's no injection that I'm going to do that's going to make that better. So what we'll find is that, I'll have them see a surgeon first, fix the bucket handle tear, and then we'll use a regenerative treatment afterwards to augment the healing. So why are we trying to avoid surgery in some of those cases? We mentioned that study that looked at surgery in meniscus tears and osteoarthritis. They can do a perfect job of fixing the meniscus, but it's going to irritate or aggravate the arthritis symptoms. And so coming through afterwards to do an injection with the plasma or one of the other regenerative treatments can help manage that arthritis flare. So now that you have healing of the meniscus, we manage the arthritis and you're not getting new symptoms after the surgery. Another question that just popped up in the chat was, can PRP or regenerative therapies treat neuropathy?
This is Heather.
I'm not too familiar with the research around PRP and nerve pathologies or nerve injuries. I don't know, Dr. Farrell, do you treat neuropathy or nerve injuries with PRP?
Yeah. So to my knowledge, the data on neuropathy and regenerative medicine is pretty limited. There is good data to support nerve treatments with platelet-rich plasma, such as carpal tunnel, ulnar nerve entrapment, things of that sciatic nerve impingement, so that we have good data to show that PRP can be helpful to heal impinged nerves and nerves that are being compressed.
I'm working at disability.
Specifically,
And my income is
anybody who's not on mute, please mute. Thank you. And then specifically for kind of the neuropathy, I haven't seen much data out there for neuropathy. There is some anecdotal studies that I've seen using shockwave or EPAT, which is another kind of modality where it's a machine that's going to put shock waves similar to ultrasound waves to add energy into the foot or ankle, and that can increase blood flow or angiogenesis. And that has shown some anecdotal data that may be beneficial for neuropathy, but we don't have great studies to say that regenerative medicine is going to help out neuropathy alone. There's also some anecdotal studies on something called perineural prolotherapy. This is using 5% dextrose to inject around the nerve roots. And there's been a couple of case studies showing that it's improved neuropathy, not double-blind randomized controlled studies that I've seen there. All right. Any other questions to the group? Well, I want to thank everybody for attending. I want to thank Dr. Tefera for providing us with this excellent lecture. I think we're going to plan on taping this and then publishing this to the website on YouTube. There's a link to our YouTube page on our regular ROSM website. So if you want to share with any of your friends or families, if you have any questions that didn't get answered today that you kind of think of later on, you can always send those questions to info@rosm.org, and we can try to get those questions answered for you. But I thank you guys for taking the time out of your busy day to join this webinar, and really appreciate all of the interest and all the questions.
Thank you.
Thank you all.